This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
What's hard is that it's no single player or no single solution. What is so exciting is mostly what I found is collaboration, and it's how do we work together to create this system for patients. The one thing I would say that stood out the most before I give some examples is that every single one said they devoted their success to the collaboration efforts that they did with the community.
Welcome to SG2 Perspectives. I'm your host for today's episode, Jayme Zage. I am excited to have my guest on today, Jennifer Goff. She is our SG2 expert for behavioral health services, and she's going to talk about what is happening with crisis care and what's happening in the ED. To set the stage for this, behavioral health patients and their navigation through ED services has always been a challenge. Through the pandemic, we saw a lot of shifts in how patients accessed ED services and how we manage those crisis patients. There's been a lot of changes since then. I wanted to bring Jen on to talk about that and some of the exciting, innovative models for crisis care. Jen, why don't we start with where we are today in terms of crisis services and how behavioral health patients use the ED?
If we take a step back and we look at what are we seeing in the emergency department when it comes to behavioral health, we saw during the pandemic some change in utilization, and we continue to see that. When I looked at the Vizient clinical database and looking from 2022 to 2024, what we saw is overall behavioral health ED cases continue to be more flatter. But when you start to dig a little bit deeper, what you see is a slight decline in the outpatient ED visits, so those treated and released. But those that are being admitted to the inpatient has been rising. And when you actually go a little bit deeper into subset, the older population actually has been rising in the ED for behavioral health. But then there are those select conditions within behavioral health. The key when you talk about behavioral health and ED is that it's very local. I looked at it at a national lens through the Vizient clinical database. I also then analyzed by state. And what I saw is the story is so different. There are some states that are starting to see some declines. And I could talk about where we're seeing, I think, crisis care services that are being expanded are contributing to that. But then there are other states that are seeing continuous growth. So it just reminds us it comes down to those local dynamics. Similar things in the ED that we continue to see with behavioral health that we've seen for, I think, many years is I'm doing a publication right now regarding trends for behavioral health and ED and crisis. And as part of that, I looked at Vizient clinical database and compared a behavioral health patient to a physical health patient in the ED to see how the outcomes are slightly different. I was not surprised in what I found. These are things that we've been hearing for many years. The first big thing is a behavioral health patient stays in the ED 2 to 4 times longer than a physical health patient. To give you a perspective, from the Vizient CDB data, what we saw is an adult behavioral health patient is typically in the ED around 9 hours, where someone that has a physical health is less than 4 hours. So you're talking these are some pretty big differences. To no surprise, I also found that behavioral health patients are more likely to continue using the ED. So their ED readmission is a lot higher. They're also more likely to be admitted. At the same time, they're also more likely to have Medicaid or no insurance at all. When you think about it from a hospital ED perspective, this is an operational and it can create bottlenecks and throughputs with the longer lengths of stay and complexity, especially because they're more admitted patients. What we also know that this could impact financial and workforce as well. Financially, when you are utilizing more resources in the ED, but your reimbursement is most likely going to be lower. That's another key. That it wasn't surprising to see those results because this is things that you hear people talking about all the time. I just put some data to it. That leads to the great work that I'm seeing around crisis care. The great news is that there's expansion on crisis care. So to get us transitioning here,
one other thing I wanted you to touch on before we dive more deeply into crisis care is thinking about disease incidence and prevalence as well. Because what we saw during the pandemic was an increase in incidence in mental health disorders, in particular mood disorders, anxiety. And some of that was related to individuals self-reporting where they had been stigmatized to self-report before. So they were underreporting because of that stigma. Are we still seeing that stigma be relaxed and softened compared to what it was pre-pandemic? And is that part of why we're seeing continued demand for services?
Absolutely. We are continuing to hear that the stigma is coming down. People are feeling more comfortable to talk about it. That was such a great win from the pandemic. It made people feel it's okay not to feel okay and to talk about it, which is great because it allows that people are seeking care earlier. And at the same time, we continue to see integration of behavioral health, expanding more into primary care, but into specialty care, which means that people are talking to their doctors about their mental health while they're seeing and talking about physical health. So it's making them feel more comfortable. Virtual has also created that reduced stigma that people are like, I can be at home and feel more comfortable talking about mental health. There's still work there. I think there's still some stigma around it, but it has definitely come down and we are seeing that. But the thing is, we're still seeing access challenges on the outpatient, particularly for those that have a government insurance. There was a recent report that the government put out that surveyed behavioral health providers, particularly around Medicare and Medicaid. What they found is 45% of the providers they surveyed said that they were not accepting new Medicare and Medicaid patients. So it really shows there's still an access challenge. Even though people might feel more comfortable, there's still an outpatient access challenge, particularly for those that have a government insurance.
Yeah, absolutely. Pivoting back to crisis, and you mentioned a few of the things, the integrated health models, but what else has come into play over the last 5 years or so that is helping us to do crisis care better?
So there are multiple. The good news is that crisis care, particularly in the community, has gained a lot of initiative across national, like from SAMHSA, even down to state levels and so forth. So it's getting more attention and more investment. A couple of examples of what we saw is that there's an organization called NRI. They track information from state mental health agencies, and they are now starting to track how are state mental health agencies investing into crisis services and doing annual report out on that. What they found in 2024 is that state mental health agencies reported that they invested more than $300 billion in crisis services. What that $300 billion represents are providing services to hotlines, particularly around the integration of 9888. Then it includes investing in mobile crisis units, as well as creating these places for patients to go, such as crisis centers, as well as crisis stabilization units. So you have state mental health agencies now are interested. The Transition 988 created this whole thing that now we're all providing funding to create this transition to a simple 3-digit crisis hotline. And what we saw is states also are like, well, we need more beyond this. So now they have an interest in investing. At the same time that has been happening, there has been an expansion of certified behavioral health clinics, or CCBHCs. And those that aren't familiar with those clinics, they, as part of being a certified clinic, they have to have 24/7 crisis services, which typically include a mobile crisis unit or a walk-in crisis center, or a combination of both. And what we have found is significant growth across the US on them. So to give you a perspective, is when they originally implemented the CCBHCs in 2017, it started with about 66 clinics in 8 states. And in 2024, it was reported that they have almost 500 of these clinics across 46 states. And a lot of that expansion is being driven by SAMHSA has been doing a lot of expansion grants to help expand out more. There is more interest from states to do this. So now we have this combination of state health agencies investing money. We have the expansion of the CCBHC is happening. And then SAMHSA earlier this year updated their national guidelines for crisis services to make it more of a comprehensive guideline for states and organizations to build out a more robust crisis service. So it's getting a lot of attention from multiple organizations. There are 3 pillars now that we're seeing for crisis services. There's what's referred to as someone to contact. This is going to be like your crisis hotlines, your 9888. And then they have someone to respond. This is going to be your mobile crisis unit or an outreach team that's being dispatched to on site to respond and de-escalate. And then there's a safe place for help, where we're going to see more hospitals playing, but this is like your behavioral health urgent cares, your crisis stabilization units, your psych emergency department, as well as like an empath unit, really playing in that safe place for help. But what we're finding is most of these crisis systems are using these guidelines and using these 3 buckets to say, okay, this for our system, this is what we have for where to contact, who's going to respond, and where are they going to go for help.
That's amazing organization around what is a really good crisis model. There's been a lot of innovation within that over the last 5 and honestly 10, 15 years, but we're getting to a place, right? It's almost a tipping point. We're starting to see it move forward, and partly because of this state level investment through SAMHSA. But what are some of your favorite models that you're seeing?
What's hard is that it's no single player or no single solution. What is so exciting is mostly what I found is collaboration, and it's how do we work together to create this system for patients. As part of the work and the research that I was doing on this publication that I'm putting out, I talked to a couple of our members on some of the things they were doing as part of elements of the crisis system. And the one thing that stood out the most, before I give some examples, is that every single one said they devoted their success to the collaboration efforts that they did with the community. There was something with community partners, and they're like, we couldn't do this without them. I heard a lot of that in a lot of the conversations I had. I'll mention, I got to talk to Parkland. They're in Dallas, Texas. They have collaborated with their county, first responders, community behavioral health providers, as well as 911, and they created a program called Right Care. Ultimately, this is a mobile crisis response team that responds on site. It was a collaboration that started with a pilot in one community, and it was multiple stakeholders together. What was so unique and exciting about this is everybody has some part to play. So the community provider provides a clinician that's actually embedded into the 911 center to help triage calls to say, okay, this is a behavioral health crisis. Let's dispatch the mobile team. The mobile team includes law enforcement, the EMS, as well as Parkland social worker. They all go together to on site when they're dispatched. What I heard is that they all have defined roles. So law enforcement ensures safety, EMS does the medical check, and the social worker that Parkland has, they do the assessment and the behavioral health intervention. What they found is most of this they can actually de-escalate on site. They were able to, during their first pilot of this, divert patients away from the emergency department as well as jail. They're able to connect these people to resources. Sometimes it's connecting them, getting them a follow-up appointment on outpatient right away. Sometimes it's as simple as getting them the needs that they need and connecting them sometimes to housing as part of this. They started with one pilot. Forget the exact year. It was pre-COVID. And now they've expanded it to all of Dallas and the whole county. They were able to show the success of it. I think it's just so much collaboration that was involved. The other one I got a chance to talk to was University of Kentucky. They added an empath unit last year. So I think a lot of people were all familiar that the empath unit's been around and all the great work that they do. What I heard from University of Kentucky when I talked to them is their empath, instead of having it next to the emergency department, it was about 5 miles away, but they do coordinate and patients can be directly sent to the empath through EMS, police, or even walk-in. And they did a lot of the similar that we hear that most empaths do. But some cool success that I heard from them was they were able to coordinate post-discharge follow-up for most of their appointments within 48 hours. So they collaborated with community partners to ensure these patients had follow-up. About 65% have a follow-up appointment compliant, which is a great rate to have because this will decrease people returning back to the empath. So they've had success there partnering. Sometimes they transport patients because they have their own transportation and van. The other interesting thing that they mentioned was since they've had the empath, they don't need sitters. Prior to that in the ED, they used a lot of clinical staff in the emergency department to sit with patients. So what they've been able to do is quantify the number of clinical staff hours in the ED that return back to the bedside by having an empath unit. It's very similar stats they saw that we usually see at empath, but some uniqueness with them. It was good to just hear that it was been a year by the time I talked to them. I think it was 11 months in, they were in and they were just having so much success with the program. We actually had a podcast earlier this year on SSM urgent care. That's just another great example. That's part of a crisis system as well, those urgent care and walk-ins.
We can certainly put a link to that podcast in our overview of this one. Given all the innovation that you've seen and how you have seen variation in adoption of crisis services across the country, for those who are still moving in that direction, what would be your advice? And for those who have already gone there, what's next for them? What should they be thinking about next?
Even though we've seen a lot of expansion and investment interest in these community crisis services, there was a recent report that came out that showed 1 in 10 adults reported through a survey that they had a crisis last year. And when they asked the question of what services did you use if you used a service, which not all do, what they found is about 20% of them used formal crisis services, 988 and mobile crisis. If you do have one today, there's still a lot more awareness needed for the community, and continuing to be aware of that and making sure people know this is where you go, and educating. So a lot of how do I educate and advocate within the community around how do you respond? First of all, what is a behavioral health crisis? And then when you notice one, what do you do? What are the steps I should be taking? And that should be education across both those that experience a crisis, especially family and friends. There's that piece for those that have been working in this journey. But I think there's also, if you haven't begun this journey, the first thing to be thinking about is you can't do this alone. Everything I researched and read, this is a collaborative effort across multiple stakeholders. Most programs that I read are a lot of times funded through multiple types of funding. That this is not going to be your usual fee for service, bill for the service that covers the cost. This is going to be multiple sources and built funding for it. There's 3 ways that I would think about this. Is first, I would definitely do a internal assessment and understand your current emergency department. Currently today, how are behavioral health patients utilizing your ED? Where do you have opportunities? So really doing that internal assessment first to ensure if you're seeing a lot what we saw nationally, they're utilizing the ED more, they're in the ED longer. I would definitely first assess there where you have your opportunities. I would do an external and understand who's currently doing crisis care in my community today. Where do we have gaps? The publication coming out in a couple of weeks, what we included in there was our system of care, but the system of care of crisis services to really show what are the different crisis services across the different access points. So definitely doing those gap analysis for your community to really see where are their current gaps, and then collaborating with different partners. If you're not talking to your local government, first responders, definitely start to bring those stakeholders together. You may also want to include payers as part of this. They benefit from crisis care if you're diverting from the hospital. Definitely bringing those together to say, how can we strengthen this crisis continuum as a whole? This is really a collaborative effort, as well as what outpatient access gaps exist. A lot of communities still have those. And then thinking about how do we sustain for the future? And that's where I think scenario planning can be really helpful. If you think about it from an ED perspective, behavioral health, we know the incident rates are rising. We know more people are seeking care, or if they're utilizing the emergency department because they can't get into outpatient, they could be very costly to your ED. So how do you scenario plan and think through these efforts that we're doing or collaborations with our crisis care partners or community partners? How can that help alleviate our hospital and ED? That's really a third one. But in short, it's how do we position our hospital across this care continuum? Because we're not going to be able to solve it on our own. This is going to require a collaborative approach.
That's some great advice to end our episode on. Thank you, Jen, for being part of the episode today and sharing your latest research in this space. It's a passion of mine that I've been involved with as well for many years. And the ED in particular was always a place I know we can do better. We're starting to see some of that come to fruition. So it's exciting. Thank you to our listeners as well for listening to SG2 Perspectives. Until next time.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You could find them at Vizient /podcasts. Have a great day.